Okay. Secretariat, can you just confirm if I am audible and visible as well clearly, please?
Yes, sir.
Oh, perfect. Thank you so much, Shivang. Really appreciate your gesture.
Thank you very much.
I can see that our esteemed speaker, Dr. Nishchal, is also with us. He has already joined in, and really appreciative of you, Dr. Nishchal.
Hi.
Thank you so much.
Hi. Thank you.
A very warm welcome and a very warm hello from us.
Thank you. Thank you very much. Thank you.
Thank you so much for joining on. We're very much on time, and we have delayed it by 6 minutes, as a few of our members mentioned that they are taking a couple of minutes to join in.
Fine.
Otherwise, mostly we start at 6:30.
It's absolutely fine. No problem.
Yeah,
No
thank you so much for your kind understanding. With that, I would like to.
That gives us some time. I just wanted to check
Yes.
what sort of group are we addressing to. So if you can just give me a brief about that.
Yes, so I will, as soon as I'm going to welcome the attendees and the panelists, I will be introducing our group as well, and will be sharing who we are, what we have done till now, brief of that, and then we look forward to hearing from you.
That's fine.
For sure. Thank you so much, Dr. Nishchal. Very kind of you. With that, I'm extending a very warm welcome to all the panelists and attendees who have spared their time and joined in for this wonderful session. I can definitely see it's a very generalist topic, but then with the vast experience of Dr. Nishchal, I'm sure we are going to have a lot of learnings this evening today, this Saturday. I'm Dr. Pawan K. Gupta, part of executive committee of AEOHD, which is Association of Environmental and Occupational Health Delhi, a branch of Indian Association of Occupational Health. It's a 73 years old organization, Dr. Nishchal, for you and to other esteemed attendees who are probably attending our webinar for the first time, or who are interacting with us for the first time. And this is the 103rd issue that we are doing today.
Yeah, I saw that. It's mentioned there. Yes.
Yeah, it has been a continuous process during COVID phase because of the COVID norms. We moved on to this platform, and usually what happens that this is recorded. Entire session would be recorded, and this is put on our platforms, on all the platforms. So we call it Lyft, LinkedIn, Insta, FB, Twitter, YouTube. We have our own channel, and it has been running since very long, since many years. One of the strongest member body in under IOH flag in the country, and this is a 3,000 physician strong body across the nation, who are part of the main revenue drivers for the Indian government organizations. So we call them Maharatna, Navratna, and Mini Ratna.
Yes.
So all the giants, ONGC, NTPC, SAIL, BHAIL, GAIL, Indian Oil, I mean, you name it.
Yeah.
So these are those physicians and those doctors and those practitioners who are keeping these entire field force of these giant organizations moving and healthy. So this is who we are.
That's good.
Yes. And I'm part of the executive body, as I mentioned, and also secretary of Haryana branch of IOH. In that capacity, once again, welcoming everyone this fine evening to hear from you and learn more, as we have been learning in 102 sessions. And this will be posted on the YouTube channel, and people who are not able to join out of this entire entire group, they visit the website, and later on they see and they share the feedback, and you will also probably people will reach out at times.
Absolutely.
Yeah. So that is on the introduction part of IOH and AUHD, and I'm thankful to the secretariat which has been supporting us all through. Shivang has been playing a key role in this 103rd session, reaching to this milestone. So secretariat is based out of Delhi itself. In fact, National Secretariat and Delhi Secretariat both are based out of Delhi, because national body is also we have secretary to the national body is the secretary of Delhi body as well.
Yeah.
So that's a very good combination as of now, and we are going to host international conference in 2027. We have won the bid of that. It's a ICO, a great conference globally. So we are announcing it in every session that we are going to host that. We are making the ground for that from now onwards itself.
Great, that's great.
So with that, it's a matter of great pleasure that I get this privilege and this opportunity to moderate these sessions at times whenever I have I'm available, or definitely opportunity is given to me by the executive body. So, and all thanks to the attendees and the panelists who have been very regular with us. Is present our Senior Vice President, Dr. Rajiv Kumar Jain. So he has been a consistent figure, one of the tall occupational health physician in the domain. One of the tallest, rather, I would say, Dr. Rajiv Kumar Jain.
Good evening, sir.
And he has been driving it from the front. So he will be definitely very listening to the session very, very keenly, and he will come back to you with a lot of queries as well. And we are very thankful to Dr. Jain for all his guidance. Dr. Langoti is with us, Dr. Maruti Langoti. Thank you so much for joining in as a panelist. And then we have our attendees, regular attendees, Dr. Damodar Lele, and then other key attendees who have been attending. So with that, just a quick one, we'll have 20-25 minutes of session, Dr. Nishchal, and then followed by 10 to 15 minutes of question and answers, because people will at times come with a lot of questions.
Okay.
And later on it will be posted as well in the group. So to the attendees and to the panelists, you can keep posting your questions and queries in the chat box. I will be trying to do best justice to the ones which are coming in their sequence, and we'll try to take up the queries.
So we can do both ways, whichever is suitable. We can do interactive whilst we go through the presentation, and we can do at the end, whichever suits. I'm okay with both.
Perfectly. That's very generous and kind of you, Dr. Nishchal. What we will do is we will finish the presentation first. It will be, and people and attendees and esteemed members will keep posting their queries, or I'll keep taking their queries in parallel, and then we'll take it up one by one as once you are done with the presentation. So with that, I am taking liberty of starting the session and introducing our key speaker of the evening, Dr. Yogesh Kumar Nishchal. A brief introduction to Dr. Nishchal. He's a senior consultant oncology at Fortis Hospital, Noida. Dr. Yogesh is a renowned name in the field of medical oncology, and he has over 15 years of experience in the domain. He has been a bright scholar throughout his career, and that we will come to know as I'm going to read further profile. After completing his MBBS with distinction, he underwent all his post-graduation training in the NHS, the UK. So most of the time you have been out of India, and we are going to learn a lot today. He successfully did MRCP, MD Medicine from Royal College of Physicians of England, UK. He went to complete higher specialist oncology consultant training from Wessex, Southampton, UK. He has attended various research and training programs in oncology across UK, India, and Europe. He has special interest in breast cancer, gynecology, lung, gastrointestinal, and hepatobiliary cancers. He has presented his research work as speaker on many occasions and published his work in international and national journals of good repute. That's a long list, Dr. Nishchal, and we are really privileged and honored to have you here with us during this fine evening. Thank you so much for sparing time. We look forward to hearing from you.
Thank you.
Over
Thank you for the introduction. Thank you. So I'm just going to share my slides. Do let me know if you can see them all fine.
Yes, absolutely wonderful. We can see it very clearly, Dr. Nishchal.
Also, please do confirm if it's moving or not. I'm trying to move.
It's moving, yes.
Good. Great.
That's good. Yeah.
Great. I hope you all can hear me all right.
Yes, very clear to me, and I'm sure everybody can hear. Yes.
So thank you for having me today. And I would also like to thank Viresh from DELAC, who has arranged this with your coordination. And I welcome you all for this meeting today. And thank you, Dr. Gupta, for the kind introduction you did.
My pleasure.
First of all, I would like to say this is very general talk, and the idea is to go through the do's and don'ts. But I've just put some brief introduction about oncology and cancer as such, to put things in perspective and also to give an idea about what's going on in the current scenario. So you will get a bit of a taste of what's going on and in what way things are changing in oncology world. With that, we will make a start. So this is just an outline. So we'll go through introduction, the basics, the types, the diagnostics stages, the treatment modalities, the screening. We'll go through molecular testing and genetics. We'll talk about what the well patient means. We'll talk about the red flags in oncology, and we'll do the what to do and what not to do things in oncology. This is totally my own, you can say, kind of experience and my own thoughts into the do's and don'ts. And I'm sure we'll have a lot of questions and interactions later on, and I would welcome that, because that's the way we learn. So with that, let's make a start. So these are just few of the definitions of cancer, which I have taken from different websites, and you can see what is cancer for anybody. So there are a lot of definitions out there. So cancer.gov from USA suggests it's a disease in which some of the body's cells grow uncontrollably and spread to other parts of the body. So nice and simple. In Cancer Research UK says it's when abnormal cells divide in an uncontrolled way. From Cleveland Clinic, it says cancer is a disease that develops when cells in your body divide at a faster rate than normal. And WHO has got a kind of bigger definition, where it consists of a large group of diseases that can start in almost any organ or tissue of the body when abnormal cells grow uncontrollably, go beyond their usual boundaries to invade adjoining parts of the body or spread to other organs. So quite a mix of comments here in different definitions. What one thing is common is the abnormal cells and uncontrolled cells. So that's what it means. Abnormal cells which are collecting in one place, whether they are dividing rapidly or slowly, but over a time, they will come up as what we call as tumors. That's what cancer is. Now, the basics of cancer, what we normally do, I'm sure we all are familiar with this, but just to give a brief, you can talk about different types of cancer based on the organ. So which is the primary source of cancer? It can be lung cancer, breast cancer, brain, prostate, and so forth. Or there is histopathological diagnosis where we call them either carcinoma or a sarcoma or a myeloma or lymphoma or leukemias. As we know, there can be some mixed cancers as well. So leukemias and lymphomas, as you know, are usually what we call as hematological malignancies or blood cancers. And the carcinomas and sarcomas are usually solid malignancies. And the myeloma is a bone malignancy, as we know. The diagnostics part, we all know that we do all these tests to come to a conclusion, to get a definitive diagnosis, to stage the disease. So these are all at our disposal. So we do the usual routine bloods, tumor markers. There are imaging which helps us, including chest X-ray, ultrasound, CT, MRI, PET scans. Then we have got FNAs, biopsies. I've put FNAC because I think there is very limited role of FNAC. And that's only when we talk about recurrences and we want to confirm something, then probably FNAC has got a role. But in my books, usually it's a biopsy with IHC. And there can be occasions where we do bone marrow aspirations and bone marrow biopsies. Then we have got endoscopies. EBUS is the endobronchial ultrasound, colonoscopy, upper GI, or ERCP. And there are special tests like choline or PSMA PET scans, which gives us a bit more information about the activity of the disease. And we have got Dotatate scans, which we do for neuroendocrine tumors. So these are kind of common diagnostics which we normally apply in our day-to-day practice. Now, stages is commonly divided based on the old TNM method, which is tumor size, nodes, and METs. There are exceptions to this rule. For example, the brain tumors, they are not divided based on TNM. They are based on WHO grading. The reason being because they don't usually spread out of the brain. at the most they will go is into the spinal canal, because that's where the cavity is from the brain. But usually the stages are from 1 to 4, 1 being the earliest, where it's localized to one place, and it's of a usually very small defined size, usually less than 2 centimeter in size, you can say, majority of the times. Stage 2 is again the size dependent. So if it goes beyond up till say 2 to 4 or 2 to 5 in certain cancers, that's what stage 2 defines. And when the nodes come in, usually if the nodes are positive, N1 or N2 disease, depending on the cancers or the primary site, we call it stage 3. And there are certain cancers which are divided further into stage 3, stage 3A, B, C, and then we have got stage 4, which is when we call that when there is distant metastasis. So that stage 4 is usually what we call as incurable. Exceptions to this rule are there. For example, lymphoma or germ cell tumors, even in stage 4 cancers, can be curable and are curable. Talking about the treatment side, there are options in treatment. We talk about active surveillance, especially for prostate cancer patients. Then we have got options of surgery, chemotherapy, and radiotherapy. These are the 3 pillars, you can say. But in the more recent times, over the last 5-10 years, we have seen a lot of developments happening in the systemic side of things. So which consists of immunotherapy or targeted therapy, which can be single target or multiple targets. We have got vaccines. One of the vaccines, which is BCG, has been used for a quite long time for bladder cancers, superficial bladder cancers. We have got now HPV vaccines in cervix cancer, and there are more research going on in vaccines. And then there are combination of above therapies where we combine chemotherapy and radiotherapy, or we combine chemotherapy mixed with surgery followed by chemotherapy. There are various ways of dealing different types of cancer. So this is just a brief outline of what are the options available for treatment, and that depends on what stage the cancer comes and obviously the patient profile to decide on what's the best treatment for that particular patient. Moving on, talking about screening. Again, screening means you're not meant to diagnose things on screening. This is just to screen patients so that you can pick up those who may have potential cancer. Why do we need to do screening? Because it does reduce mortality, and there have been a lot of studies based on this. And we all know in the Western world, in the UK, US, or in the higher, more developed countries, there's a lot of screening program already in place. So it's basically site-wise. So if you talk about breast cancer, we know about mammograms, which is usually done between the age of 40 to 74. We have got MRI scans, especially in the mutant BRCA, which is the breast cancer gene, positive patients, or in those who have got dense breasts, especially in the younger female patients. Then for cervical cancer, we have got HPV screening or pap smear. For colorectal cancer screening, we have got fecal occult blood, colonoscopy, sigmoidoscopy. For lung, usually low-dose CT scan has been used, but it's not a common practice, even in the UK or in the Western world, just because of the risk of radiation. So low-dose CT is an option, but it's not done at a national scale. For liver cancers, we do have AFP marker, which is, if very high, we are usually very diagnostic of liver cancers. For ovarian cancers, there is CA125 marker, and then there is transvaginal ultrasound, which helps in screening patients. For prostate, we all know serum PSA and digital rectal examination does help in picking out patients. So these are just brief outline of site-wise screening tests available. We talk about molecular testing, which is the buzzword these days, and genetics. So molecular testing is basically understanding the biology of the tumor. So, and that is done by going through various set of tests or markers, which are defining how the tumor grows in a particular patient. So these are site-wise. I have outlined the most common ones, which we are doing in practice. And this has been there for, say, at least over the last 5 years. And the number of these tests are on increase. So for lung cancer, we do EGFR, especially in adenocarcinomas, ALK, ROS1, these are translocations. Then there is PDL1, then there is RAS, BRAF, MET. So these are all molecular markers, you can say, pathways through which the cancer is growing. Similarly, for colorectal, we have got RAS, BRAF. There are some common ones you will see. Then we have got DMMR or MSI and PDL1, PIK3CA. For breast cancer, traditionally we know we have the breast cancer treatment is based on these parameters of ER, PR, HER2 markers. Then we do Oncotype DX which is US-based company who does it. We have got Mama Print. And these are again tests to see which patients will suit or will benefit from treatment like chemotherapy. Then BRCA1, BRCA2, which is commonly advisable for anybody with breast cancer under age of 50, or if it's a male patient, or if there is a strong family history. For brain, we do certain tests like 1p19q deletion to see whether it's chemosensitive or they will respond to chemotherapy or not. We have got IDH1 and 2, EGFR. In head and neck cancer, again, EGFR, PD-L1 commonly used. Sarcomas, we do GIST, the gastrointestinal stromal tumors. The kit, actually, this is the one which started the tablet therapy. If you remember, imatinib came in with the Philadelphia founding of Philadelphia chromosome, and this was one of the great success story, you can say, for oncology from that point. It was, I believe, in early or late 80s. In melanoma, we do BRAF. In prostate cancer, again, we do BRCA testing, and there is HRR testing, which has been started over the last couple of years now. So next gene sequencing is the word which we are normally using these days, and this basically means it's a test which goes through a number of genetic mutations, and it's very easy to do, and the cost was an issue, but things have been changing rapidly. But we have got next gene sequencing, which can do, say, from 15 genes to more than 1,000 genes. So depending upon what you're trying to find out, you choose a package and you do the test. So more or less, on average, I would say it can cost anywhere from 15,000 to 50,000 for a good next gene sequencing test. So this is the buzzword about molecular testing, and this is what leads to what we call as personalized medicine. So people who have got certain mutations will benefit from certain drugs which are available in the market, which are in clinical trial, ongoing. So when the test comes out, they give you full report of which mutations are positive, and they will give you which medications are currently available in the market or currently undergoing clinical trials. And that can be anywhere in the world. So that's a very good report which you get from good companies, and that's what we rely on. So these things are in progress, and as we speak, there are a lot of these tests coming up now, undergoing validation and giving us more specificity and sensitivity to rely on these tests. Moving on, the well patient. So well patient, what I mean to say is the patient who comes to you with some symptoms which are vague, which are not specific, and we struggle to find out what's going on with this patient, clinically I'm talking. So they come, you give something, they go back, they come back again with some symptoms or similar symptoms, and they keep coming at you. And you find it very difficult to put a finger on. I'm sure we have gone through a stage, and we still go through people who come with these kind of symptoms, and we find it very difficult to find out what's going on with this person. There's no usual signs to pick up. The initial tests can be normal, but these are the patients who probably are not showing up properly, or where the disease is in an indolent stage where they're not showing up properly. So these patients should not be lost to follow up. They should be encouraged to come back when they find more symptoms or they find some signs which will guide you towards finding out what's wrong with that patient. And in these kind of patients, we normally say, encourage them to see a specialist early on. There can be subtle things which are difficult to pick up and they need. And, I've seen patients recently as well where things were not very clear, and we are still investigating those kind of patients. So this is what I mean by well patient. Then we move on to the red flags. Now in India, specifically, only 20 to 30% cases are detected in early stage, which is stage 1 and stage 2. There was a study done in 2017, which was a community-based cross-sectional study in over 300 patients, and they found a number of symptoms which they thought were more consistent in majority of the cases. That's why they have said these are the red flags. So if you see them, you have to act on them, and as a matter of urgency. So these are the outline symptoms of persistent cough, persistent change in bowel bladder habits, non-healing ulcer, persistent difficulty in swallowing, unexplained weight loss, unexplained lump, persistent unexplained pain, or unexplained bleeding. Again, this is not only about symptom, this is also about in context of how long this has been going on. As we all know, we all have a limit of saying, okay, this is too much. this is going beyond the timeline, and we should then refer the patient to a specialist center or a specialist doctor to see. And it will be interesting to know what people think of their timelines when they do this practice, because I have my own suggestions on this, and we'll talk about that. Moving on. So message is loud and clear. Efforts at the primary health care or community level, or where the patients come first in contact, are very, very important for early detection of cancer, since majority of patient contacts in India occur at the primary care level. So as you know, corporate hospitals hardly get direct patients coming to them unless they're very affluent, well off with their financial sources, or they belong to a certain panel where they don't have to pay. Otherwise, majority of people will see their local doctors or primary physicians locally. So early detection of cancer is more likely to respond to effective treatment, resulting in greater probability of surviving, as well as less morbid and less expensive treatment. So I just wanted to highlight that whatever money is spent on cancer and other illnesses are all our money, which is taxpayers' money. So we have to judge by what's coming and try to get things early on so that we reduce the overall cost of treatment. So somebody in stage 4 cancer requires actually more resources. You know, they may live for 6 months, but actually the resources we spend on them can be huge if you talk about it. In India, unfortunately, we don't have the palliative care services, which is coming up slowly. But in the Western world, palliative cancer centers or palliative centers in themselves are a huge place where patients in their terminally ill stages of their cancer, or even for symptomatic management of their cancer-related symptoms, go to palliative care. So symptom management and terminally ill patients go to palliative care centers in the Western world. So in India, I think things are slowly beginning at this point in time. So what are the do's which I believe personally that we all should do at our levels is to keep yourself updated. You've got a lot of online materials available, physical CMEs to attend, and these are all learning modalities for us. Always take proper history. We all remember from our medical school days that 80% diagnosis is based on history, and we do investigations to confirm our doubts. That's what, and that's how we were taught. I'm sure many would agree with that. Then try to do a full physical examination if you can, because it doesn't take long. If you're systematic, it probably takes only a few minutes to do a full physical examination. You may pick up a vital sign, which otherwise patients may not be aware of, or they may not be able to tell you. Then try to do the routine blood tests early on, which we normally do. So all the routine count, CBC, KFT, LFT, you may have certain signs there. You may have abnormal calcium, hypercalcemia, or there may be some microscopic hematuria in the urine, which you can take lead on from these tests. Have a high index of suspicion. Always follow your gut or instincts. If you think something is wrong, something is wrong. You have to act on that. You can't say, I will wait for another few days, another few months. You have to act soon on them and get things done early. If you believe that a person needs an MRI, do an MRI. Don't do X-rays to start with. Just get an MRI, because you get more information, and the early the information is there, early you can make a decision. So if in doubt, refer early to a specialist unit, like Fortis, for example. Then discuss with the specialist. We are very much approachable, and I'm more than happy for people calling me for any advice regarding any suspicion of cancer patients and having a chit chat about it. Early screening or diagnostic tests as required, please do it. Answer queries tactfully and give hope to patients. I think I've seen over the last couple of years since I've been in India, patients come with lost hope because they have been told by their local physician that you can't get, for example, gallbladder cancer is very common, especially in this part of UP as a whole. I mean, these are world statistics I'm talking about. Northern India is known for highest number of gallbladder cancers. And unfortunately, we don't have much screening going on here, or we don't have much awareness programs. And there's a lot of people, I mean, I remember a day when I saw 3 new gallbladder cancer patients in one day. So I believe early screening has got a role. Just simple ultrasound can pick up these things early on. So answer queries tactfully. Don't tell them that you don't have anything, you can't treat these kind of cancers. Please don't do that, because there's nothing which we can't treat. We can treat all kind of cancers in any given stage, as long as the patient is reasonable to have a treatment. So educate patients if possible, if agreeable. Lifestyle factors are key. We know exercise and the kind of food habit is important to educate the patients. Encourage cessation of bad habits, smoking, tobacco, excess alcohol, and develop good habits. I think they all have a role to play. And most of all, look after yourself. You are special, you are vital, because you have to do all these things. So remember, role of being an educator, role model, and so forth, being a doctor. I think things have changed a lot in this scenario, in this current situation, but still I think we have got a role to play, especially in diseases like cancer. Then talking about don'ts, which you should not do, try not to do. Don't use tumor markers routinely, because these are not diagnostic tests. I have seen people who come with all tumor markers done and we don't know what to do out of it. So that's a waste of resource, waste of time, and we don't know what to do. And even the guidelines don't suggest to do tumor markers routinely unless you've got a particular doubt. For example, somebody with ovarian cancer, you want to do a CA-125, absolutely fine. You can go ahead and do, but don't try to generalize tumor markers, because these are acute phase reactants like CRP. They can be up in any infection and they can confuse people. So they're not diagnostic, remember, and they make people more anxious. So don't do unnecessary investigations, because time is critical. If there is a suspicion, as I said, go for the right test. Do a CT, contrast CT. Do a PET scan. You can do a PET scan as well. If you think there is a hard evidence, you have found something, lump somewhere in the groin or something, and you want to do a test, do a CT scan. It's not a problem. Discuss cancer diagnosis. So don't discuss cancer diagnosis directly with the patient. A lot of people come here and say, I've not told my father or mother. Please don't tell them anything. Just discuss with us. We have only told them that this is infection, that kind of thing. To a certain extent, probably it does matter. And I think in our context, because a lot of people still have social taboo about talking about cancer, it will take time before things change, because a lot of patients come from rural areas. They don't have understanding and they don't want to talk about cancer word as such. So normally we call them in the clinic and we say, Aapko gaanth hai, hum gaanth ka ilaj kar rahe hain. So that's all they understand and they're happy with that. So I think it has got a psychological benefit, I suppose. So I would not discuss at a primary level directly that you have got cancer and you've got only so many months to live and so forth. So don't discuss cancer related data, especially prognostic data. Leave it for the experts who will talk to them in the way they have been trained to do so. Unless you have had the training and you are definite about what you're talking about, then absolutely please do it. Otherwise, please don't discuss the cancer related data. Then don't talk about role of different treatment options. So don't talk about what radiation will do, what chemotherapy will do. You can give a brief idea, but to go into any kind of detail will only confuse people. When they come to us, we talk in a different way, and they will say, oh, mere doctor sahab ne to kuch aur bola tha, aap kuch aur bol rahe ho. So that can confuse people. So best avoid that. Don't be negative. You're in a position where you're supposed to give hope, no matter what the condition is, and avoiding unnecessary and futile comments and views about any condition or the patient themselves. So don't just treat the symptoms, try to identify the cause. So if somebody is coming with pain, for example, again, 2 or 3 times in the last 2-3 weeks, see what is causing the pain, think about that, do a scan early on, because your timely action can save lives. You have seen people who present with metastatic disease, for example, in the spine, and there has been delay. I have seen delays of more than a year as well in the community, where people think this is pain, musculoskeletal, and actually it turns out to be cancer. So early intervention with right investigations will help reduce mortality and morbidity of these kind of patients. And again, don't work too hard, enjoy your work and life and socialize, because this is the way we interact, and we'll try to keep our momentum going on with what we do. So with that, I would say thank you for listening, and we're up for discussion.
Thank you so much, Dr. Nishchal. That was wonderful. I, not for the sake of saying that every webinar, every talk, we have to say that it was very good, it was wonderful, but I mean it from the core. That was very simple. And as you rightly mentioned, your own work, which you have presented, your own thoughts, very original, and out of your experience of 15 years. So we value, respect, and honor that. And I'm very impressive from the point of perspective that we as physicians, we are not all experts here, definitely. And as you rightly mentioned, we have to leave few things for experts, as they have to take call and final decision. So the chunk here is that which would benefit from this session for sure once they go back and see on our channel or the attendees and panelists present currently here. We are really thankful to you for presenting your original and very own thoughts, and also sharing those key knowledge aspects pertaining to what needs to be done and what we should avoid. A couple of things which I definitely noted down were the well patient perspective. I heard for the first time probably, and the red flags. Yes, it was very well explained, and this is going to be with us. This recording, we'll definitely refer it back as and when we need. And definitely, you rightly mentioned, get the MRI done if it is needed. Don't start from the X-ray. Good touch points. The way I'm taking it, there are a couple of questions in my mind before I open the floor for the panelists and attendees. What are the key difference that you find in approaching a cancer in attending in India, and from your experience in the developed nation like UK?
So I think there are two aspects to this.
Yeah.
One is the treating aspect, the clinician aspect, and one is the patient aspect.
Okay.
So if you talk about clinician aspect, obviously there is a difference in training, I believe, and in how you approach. So things are more practical, I would say, in the Western world, because even the MBBS training is now different from how we are training our MBBS students here. So they have incorporated things like foundation training, where you go through a phase of acute training. So idea is that any student who's going to become a doctor should be aware of how to deal with acute patients, for example. No matter what you become later on, a general practitioner, a surgeon, or a professor, doesn't matter. If somebody is ill in front of you, acutely unwell, you need to have an approach where you can do something for that patient. So that's one very big difference. And that actually establishes the thought process. So when you're doing your higher training, that is in the back of your mind. And you approach patient with that in the back of your mind. So cancer patients, obviously, when they reach us in anywhere, in the UK or here, most of the time they will have all the investigations done by their primary team, gastro or neuro, wherever they present, or ENT. They come with all the reports. And that's the key. The information is the key. And that sometimes I find here, we have to do the investigations because they have not been done, or they have been left for us to do. So they have only some basic investigations done. And then because once they say, oh, this is cancer looking like, it goes to a cancer specialist. So we have to spend another week, 2 weeks to get all the investigations done. And that's probably a core difference, I would say, because as I said, the time is critical here. So if you got a diagnosis, if there are tests, so if people know what are the staging tests to be done, you can request, anybody can request, you've got power to request. And that's where we pitch in with these educational sessions to talk about what you can do at your level, what things we expect as primary physicians to do, so that it makes our job easier and less time consuming. So that's where I think is the main difference.
Perfect. Thank you so much. And the patient approach? And
the patient approach is because most of the patients in the Western world, they are more knowledgeable. They come prepared with their answers. They have seen the trials going on. So they will have questions on that, So your actually conversation starts at that level where they're already up to date with what's going on, They've had their investigations done. They have come prepared. They have been told today you're going to talk about treatment or further investigations, what the doctor is going to talk about. So there's limited time. We have got like 30 or 45 minutes for a new patient consultation. And they come prepared to talk about treatment aspect, because that's what they're presenting. Everything has been done. You have been given all the information, and you're talking about treatment. So that takes bulk of the time. Whilst here, you have to start, you can't even sometimes talk clearly that you've got cancer. You have to evade that. And obviously you need to get investigations done and get everything under one corner to get things moving. so that we know we have made a diagnosis, we've got all the investigations done. So I think
Okay.
that's where patient perspective is different.
Thank you so much for answering it in detail. I really appreciate it, Dr. Nishchal. Some echo. Okay, yeah, so it's handled. Thank you. It was probably coming from dual mic. Uh, uh, yes, information, education, and communication probably will play a key role moving forward for India. If I can put both the perspectives, information, lack of communication, lack of education, those three things definitely we are working on. I think Indian government is trying to do. We are trying because of the large population base.
Yes, of
We are
course.
still trying. Yes. So good perspectives, Dr. Nishchal. Appreciate you have shared your thoughts. The another question and the last one from my side, then the floor is open. Does oral cancer still tops the chart, or the things have changed in last 3-4 years, and now oral cancer has taken a second probably seat, and breast cancer or cervical cancer is topping the chart in terms of occurrence?
I think
Yeah.
breast cancer is still on the top. I would say breast and lung cancer still on the top.
Those are number one.
Yes, yes. So breast, lung, and prostate, I would say in the Western world especially, is
Okay.
more. In Indian context, it depends on where you are practicing. I go to Kanpur as well for a couple of days.
Okay.
Kanpur has got probably 50% of the population has got head and neck cancer because of Kanpur being the Gutka center, you know that.
Yeah.
So a lot of people, and they actually, you can write papers and volumes there for the kind of patients you see there. You know, they come young. Most of the patients are between age of 30 and 40. They have got twice or third time recurrences. Their faces are hardly recognizable. You know, it's a sad story in Kanpur.
Sad story.
But that's true, you know, because that's what the treatment also does, apart from the disease.
Yeah. Thank you so much. It's definitely a sad story. Thank you for sharing that information as well, Dr. Nishchal. Opening the floor, I have not received any question and raised hand for now, but beginning it. Okay, Dr. Maruti has raised his hand just now. Otherwise, it was Dr. Rajiv Jain to whom I was going to approach. Dr. Maruti.
It's before if the Raju Jain sir enters, I think we won't have any matter to discuss there. So, thank you so much for the excellent briefing. I have got one opinion and two questions with me.
Please.
The opinion is that, especially, opinion is that being a general physicians, we as you mentioned, you know, in history part, we get allocatives and this. Unless until we confirm that this is the diagnosis and I'm going to treat, I think we have to follow that protocol. See, generally what happens if there is a food disturbance, if there is a menstrual disturbance, we just treat casually. It is not the way actually. So unless until we have to confirm ourselves being a general physicians and confirm once and then go ahead with the treatment. And
Dr. Maruti, I think we were losing his voice in between. There was some network challenge. So we'll wait for him to come back with a proper network probably. Moving quickly to Dr. Rajiv Kumar Jain, sir. Sir, over to you for your comments, feedback. Yes, now Dr. Maruti, there is some disturbance in the voice and your voice is also breaking.
Am I audible now? Am I audible now?
Better. Yes, better.
So thing is that being a general physician, so we have to confirm ourselves that what I'm treating, whether I'm in the right direction or not. If not, we have to stop ourselves and take opinion of the experts. Even as simple as the anemia cases, I was just looking after the many anemia patients where I was ending. Few people we may end up with the thalassemia. Some cases we might have end up in the bone CAs, leukemias. And as simple as rib pains, so they may be multiple myeloma. During our experience, we are getting. So it is not. We are the very key persons in the, especially in suburban and rural areas, and we have to confirm ourselves that in what direction we are moving, and unless until we are confirmed, better not to delay the time because time is very precious. This is my opinion.
Yes.
And regarding my questions. We generally do screening for the adults, and we come across many cases of the CAs in the pediatric age group. Does it advisable to go for annual screening kind of thing in the pediatric age group? This is one question. And second thing is that cervical cancer is still is the leading cause of death in females. Does the quadruple vaccine helps in the married and gravid uterus? I mean, like having kids, like less than at least below the 40 age group or below 35 age group. Does it help? These are two my questions.
Okay. Dr. Nishchal, over to you, please.
So thank you, Dr. Maruti, and I agree with your thought process about not delaying when you see something like that. And coming to your questions, the pediatric population still the cancer is rare in pediatric population. Although if you are sitting in a pediatric cancer center, you will see all the children with cancer, but still it's very rare, and I don't think any screening anywhere in the world is going on at the moment unless there is a strong family history. I think there are some tests now coming on which we are doing whilst somebody is pregnant if there is a strong family history, but they're still in the infant stage. It's not something which is advisable at the moment. We'll have to wait for further time to see if there are things which can come up where we start doing things when babies are in the womb, for example, to do the testing, to see who will develop cancer or not, and I'm sure that day will come as well, but not for the moment. Coming to your cervical screening, the vaccines which we are using are for ages between 12 or 13 to 26 years. So anybody up till the age of 26, I think they can get the vaccine. Whether they have effect on gravid females, I'm not very sure. But this is the age group which is recommended for the vaccines for cervical cancer. The early, the better, I would say. So the idea is before they become sexually active, that's where you should give it, or even before they're married. So I think it's to do with when they get married and settle down. So probably not beyond that age group as per advice from the vaccine makers, I would say.
Okay.
Thank you so much, sir. Thank you.
Thank you so much, Dr. Maruti. Thank you so much, Dr. Nishchal. Dr. Janza, if you can hear us, over to you for your feedback, comments, and suggestions and questions as well. Okay. I think he must be.
Well,
Yes.
I do appreciate the way a very simplified version of cancer do's and don'ts have been presented by Dr. Nishchal. No doubt it comes out of years of personal experience and exposure in diverse settings. Congratulations, Dr. Nishchal. A few questions that I have for you. One, India has recently started a rapid expansion of community-based cancer prevention and control strategy. And the first experiment is being undertaken in Assam. Your experience in cancer prevention and control at the primary, secondary, and tertiary level in India and United Kingdom is quite diverse and I would say rich. The question that I have for you, what are your suggestions for further improving the National Cancer Prevention and Control Program in the light of our epidemiological profile of causative factors for cancer in India? That's one. Second is the challenge of changing this patient pattern where primarily patients are presenting stage 3 or 4, while actually they should be presenting stage 1 or 2, the majority, so that it becomes more cost effective, as well as more targeted intervention could be given for stage 3 and 4 patients, because sheer numbers, stage 3 and 4 patients do suffer in not being able to afford, in not being able to access the real path-breaking or cutting-edge technological advancements in cancer treatment and palliation as well. So these two issues are there for you. Thank you.
Thank you, sir. Thank you for your comments and your questions. With your first question about, I think it's a good initiative from the Indian government, and that's probably done as a pilot, I believe, in Assam. What my suggestions would be is, I think the primary source of everything is information. So if we provide information in a layman's language to common mass. And it can be done through various channels. We have got technology, but we are not using the technology for these things in a very large scale, especially for health purpose, So I think that's one thing where I would say is information is the key in layman's language, in their local language. So if I talk about UK, for example, if you go to any hospital there, they will have leaflets in all languages, So even in Hindi, you will find there. In Bengali, you will find there, because there are people from India, a lot of people from different sects, who don't talk English or who don't understand English. So for example, Bangladeshi people, a lot of people whom I met there, they don't talk English. They're living there as dependents or somebody, but still they need to understand. So one thing we can do is, similarly, we should prepare leaflets and distribute, or through digital channel. I think education is vital. Information is key in their language to try and educate, to come up. Obviously, we'll talk about symptoms and to come and see their local practitioners. Then we have got to train the strata of physicians which we see. If you talk about rural areas coming to the city, there is, I believe, layers of physicians in between who probably don't have any experience, who have never seen a cancer patient, for example, and those people who are treating at whatever level they are, they need to be educated as well. So I think it's a huge challenge considering our population here, but it's doable because we have got people like yourself, like other organizations who are sitting in places where you can channelize your resources. And I'm sure we will need more resources, especially doctors and medics and paramedics. So we lack that structure of, allied medical professionals in the community. So you talk about clinical community nurses, for example, they can be messengers. We are not recruiting. We have got ASHA workers, but they're only limited to certain things, So we can expand in that area, especially in the rural setting, where you can train them from cancer perspective. And people like us should take those initiatives, or should look for opportunities to go and talk about these things so that people understand. I have gone to Chapra, for example, in Bihar, where there is no cancer physician, nobody. And one of my friends who's got a hospital there, they thought about bringing me, and I said, why not? So I went there, and we had a good response initially, and I'm planning to go on a monthly basis. So, people like us should go out to small places, at least for awareness purpose. So that's first part, how we can spread, the message in general, and how we can take the initiative forward from the government of India. That has to happen. And then coming on to your second question, which was, sorry, I'm trying to get to the question which you asked, the second question, sir. What was your question again?
Dr. Jan, sorry, you're available? Okay.
Do you remember, Dr. Gupta, what he asked, the second question?
Actually, I missed the second part. First part, yes, as someone, yes, I remember. And then second, what you were more related to your experience and exposure. You have wider experience and exposure in the Western world, and what it culminates in when it comes to Indian perspective. But exact point I'm missing there.
Yes,
so
yes.
Maybe as soon as he's back, he will definitely take up that question. Yes. But moving on to Dr. Shiniket Mishra, President of Haryana branch. Dr. Mishra, if you're available, comments and suggestion, and we have raised hand from Dr. Damodar Lele. Dr. Lele, I am coming back to you just after Dr. Tyagraju for your comments and questions. Dr. Mishra, if you're available, please. Okay. I think I heard some noise. Probably he was traveling. So moving on to Dr. Tyagraju. Dr. Tyagraju, if you can hear me, one of the very key contributor to our webinars and conferences, Dr. Tyagraju has been one of the prominent figure attending all 103 webinars, I would say. And he is based out of South India, and avid practitioner, patient lover, and a great contributor for the mankind, I would say like that. Dr. Tyagraju, if you can hear me, please unmute. And if you have any comments, feedback, I'll wait for a couple of seconds. Else I will move to Dr. Damodar Lele. Okay, I think Dr. Tyagraju will come back, and then we can hear his comments. Dr. Lele, you can please go ahead and ask your question.
Hi,
Can you
good
hear
evening,
me?
sir.
Can you hear me?
Yes,
Yes,
Dr. Lele, we can hear you very clearly. Thank you so much
We-
for being a regular attendee and also a key contributor to our webinars. Thank you so much, Dr. Lele. Over to
Thank
you.
you, sir. Thank you very much. Unfortunately, I have come across few patients in whom I suspected cancers, and I have realized that to diagnose cancer in the cavities, brain, thorax, and abdomen is just difficult, because by the time you think of it, most of the time the symptoms are related with the pressure in the surrounding areas. And by the time you diagnose, they are hopeless in terms of treatment. Because see, obvious things like doing a scopy for symptoms which are clear, it is easy. But these internal things, it is just difficult. And I have come across at least 5 to 6 people where the diagnosis could be made only after MRI, and that too in a very late stage. Any comment about it?
Yeah, I mean, you will have patients who will come late or who will present late, but it doesn't mean they can't be treated, because we treat all stages cancer, as long as the patient has got some sort of fitness. And remember, we have got, as I talk about NGS, we do this on a regular basis these days. And there are a lot of treatment options which come up. There can be tablet therapy, there can be immunotherapy, and you don't need to be absolutely fit as a, somebody who is very fit to have that kind of treatment. Chemotherapy, we may have apprehensions with fitness, but with immunotherapy, even with a performance status of 3, for example, we can still give immunotherapy. Tablet therapy, as long as they can take tablet, we can still give that, So there are things which can still be done. I understand that they are probably late and they've got a lot of disease, but still that can be taken care of. I'm talking about from my own experience, stage 4 lung cancers, for example, have been disease-free after treating with immunotherapies. They are less in number, but we don't know whom they will be, So somebody in that stage, and if you find something which is helping them, why not? They may live for another good few months, maybe good few years even. So lung cancer these days have become so much prominent, and it's a great example what has changed in the last 5 years, I would say. They can live on a tablet, simple tablet, for 5 years, 10 years, with nothing else to do. That's probably, it's like treating a chronic disease, taking hypertension tablets, taking these tablets, and they have got very minimum side effects. So things have changed a lot.
Perfect.
No, unfortunately, I have seen from the other side where these immunotherapies also fail.
Yes, I mean, it's not a guarantee that something is always successful. But what I'm saying is, even then, there is hope that we can try a few things. We don't simply say we can't do anything. If you send somebody.
I'm not saying that, but can we diagnose? I mean, can we make a kind of a rule that we would be doing MRI or CT for these 3 cavities every 3 years, 4 years, or 5 years? Because other way it is not possible to detect a problem.
I would not suggest doing a CT because of radiation, but if there is suspicion, you should do test early on. You should do test early. If there is any suspicion, for example, if you find somebody with iron deficiency anemia, they should have colonoscopy and upper GI endoscopy as a rule. 15% of iron deficiency anemia can be cancer patients, So they should do. You should not just give iron tablets and say, go away, eat tablets, Get the endoscopies done early on. So these kind of patients I'm talking about, if you have got a suspicion, act early. Get the CT scan, one-off CT scan. I'm not talking about regular scans, but if there is a suspicion, get that vital scan done early on. If you're not getting, because ultrasound, remember, is very much operator dependent. So ultrasound, I have seen a lot of ultrasound being negatives and CT scan showing a lot of disease, and that's very rampant, unfortunately, in India, because there's no standard to follow, there are a lot of people who are practicing ultrasound just because they have got machines, they give report and people come saying, I want nothing, but they turn out to be cancers. If there is strong history, if there is something in the history, I always go by history. You have to ask questions, relevant questions, to get proper history, and then act on that. So don't rely on one figure. That's another thing. Don't rely on one figure. If somebody comes with, oh, I've got, weakness and so forth, and the hemoglobin is coming as 9, 10, repeat that hemoglobin, maybe after a few days. do some repeat tests if there is a problem, because I have seen that in practice here as well. That one figure, don't go take your judgment. Like blood pressure, we never treat by one figure saying that you've got hypertension. You do so many routine, few days tests before you say, no, you need to start on something, until it's a very, very raised blood pressure. That's different story. But that's where we pitch in, that we have to just keep that momentum going on and do the test on a regular basis so that we don't miss them and we detect early on. So do the scans early on. If there is strong suspicion or even a small suspicion, please do the scan.
Sounds good.
Unfortunately, you have missed the point. All I am saying is by the time they come to you and you start suspecting, it is too late when the cancers are in cavities.
Yes, I agree. That's why I said there are late presentations. You can't help. Unfortunately, you can't help. I have seen good. I'm talking about this is well-educated people, they have been hiding their breast cancer. Why? Because they don't want to talk about. They felt like a lump. Now it has come out of the skin, like a fungating mass. And now they can't hide. So they have to tell, and it's almost a year. So you see, there's a lot of issues about people talking about as well. And this is, I'm treating that lady still. She is from South India. She was not talking about it. Even the husband did not know, So there can be patients like this who present late because something is in their mind. They don't want to hassle their relatives, It's something social, I would say. Very social.
Thank you so much, Dr. Nishchal, and thank you so much, Dr. Lele. I think those were very, very avid and thoughts, queries from your side. Yes, late presentation is one thing that we are facing challenge in India very much. And there are many things attached to it. Maybe the society, the dilemma, the inner hesitance, a lot of things are attached to it. The commercials, there are definitely things, connotation attached to the family's economic status as well. So a lot of things. I thank you, Dr. Lele, for actively participating and also for putting up your queries in most of the webinars and being a great attendee always, as always. Thank you so much, Dr. Nishchal, for taking up all the queries as they have come up and also sharing your thoughts in a very detailed manner. We really appreciate that. This will be with us. This knowledge bank is ours now, and we are going to keep it, and our team, our fraternity will keep referring to it. It will be available on YouTube. You will be sharing the link with you. So in case, whenever you wish, you can definitely refer it back yourself, or you can answer the queries if somebody has asked any question on channels or on the social media platforms, or we will probably approach, or society will approach, secretary will approach to you if at all we are coming up with any key query wherein we need to approach to you.
Absolutely.
With that, I think I would like to express my gratitude and thanks from the core of my heart for your time and for the time of all the panelists and attendees sparing this fine Saturday evening. We have benefited for sure. And last comments from your side, Dr. Nishchal, and then we definitely conclude this webinar.
No, I would say thank you. Thank you for the opportunity, and thanks for listening to me, and thanks for all the questions. And all I can say is I'm more than keen. I'm somebody coming from the background from outside. I'm somebody who's more open to these ideas of spreading more awareness, preventing things from happening rather than curing later on. So I think that's where the message is. We need to prevent things from happening.
Perfect. We respect and honor that perspective of yours. And with that message, we conclude today's session. We look forward to being in touch with you, and we'll bother you more.
Absolutely. Pleasure.
Thank you so much to everyone.
Thank you, Doctor.
Thank you. Thank you all. Thank you so much.
Have a nice evening.
Thank you.
And see you once again very soon.
Thank you.
Thank you.